In this lesson, we'll begin our discussion of the male reproductive system by taking a look at two congenital abnormalities of the penis. Then we'll take a look at some disorders of the testes and the scrotum, and then we'll finish up by taking a look at two inflammation and infection conditions. So let's take a look at the two congenital abnormalities first. First of all, we know that congenital means present at birth, right? So this was some type of problem with the development of, in this case, the penis of in the male. So the two conditions we're going to look at are known as epispadias and hypospadias. Let's go to a picture real quick. Normally, the urethral opening would be here on the front of the penis, right on the tip of the penis. This is known as the glans penis, right? Glans. That's where we would expect to see the opening. With epispadias, the opening would be here on the top side of the penis, proximal to the glans, and we won't be able to see it here, obviously, but the hypospadias would be on the underside. The opening would be on the underside. Okay, so that's basically it. Epispadias, the urethral opening is on the upper surface of the penis, and with hypospadias, the urethral opening is on the underside. However, regardless of where it is, either condition can result in incontinence and even repeated infections. So the treatment here is going to be surgical reconstruction. Okay. The next condition is has to do with the descent of the testes. Normally, just to kind of review for a moment, the testicles will descend from the abdominal cavity of the fetus down through the inguinal canal and then drop down into the scrotum, right? That's roughly about the seventh month of fetal life. Let's go to a picture actually. Let's take a look here. So here we can see the testicle in the pelvic cavity, right? The abdominal pelvic cavity, and then it descends down through the inguinal canal. Over here would be like right about here, and then this would be like where the spermatic cord is, right about here, and then it will drop down. So you will see the left testicle in this chamber of the scrotum, and then the right testicle would be in the right chamber of the scrotum. Remember that the scrotum is two compartments. There's a wall in the midline. So cryptorchidism is the condition that we're talking about. This is a condition where one or both of the testes fails to drop down into the scrotum properly. The testicles could remain in the abdominal cavity, or they can remain or get stuck somewhere along that descent pathway. Now, if you left it alone, a lot of times spontaneously within the first year, the testes will continue or drop down into the scrotum. However, if by they haven't descended within 2 years, then they'll get them surgically and bring them down. All right, we'll see later that cryptorchidism makes a man more prone to testicular cancer. Right, so they want to get them down. Okay, so again, this is a pretty good picture, just kind of showing the normal descent pathway. Again, you can see here, again, it can remain in the pelvic cavity, it can remain in the inguinal canal, or here, like in the spermatic cord area in the upper part of the scrotum. Okay. The next conditions are also related to the testes and the scrotum. The first one is known as a hydrocele. Right? We know that hydro means water. So this is an excessive collection of water, like a fluid, that's in between the space of the tunica vaginalis. So let's review what that is first. So here's a picture looking into the scrotal cavity. Normally, there's like a serous membrane, right, that makes like a watery type of fluid along the inner wall of the scrotum, and then that same lining, if you follow my cursor, is on the testicle. This is known as the tunica vaginalis. The tunica vaginalis on the testicle is known as the visceral layer, and the tunica vaginalis on the wall of the scrotum is known as the parietal layer. And then normally they produce like a thin slippery fluid, and that reduces friction between the skin of the scrotum and the testicle. And normally there's just a little bit of fluid in there. But look at this, guys. This is just filled with fluid, way too much fluid. And this is what we would call a hydrocele. Okay, so this occurs again, I'll read it one more time, when we have excessive fluid collecting in the space between the layers of the tunica vaginalis, right? The visceral layer and the scrotal layer. or parietal layer, I should say, visceral and parietal layer. Now, what causes this? This could be caused by a congenital defect in the newborn, or later in life as a result of injury, infection, or even tumor. If, like in this picture here, there's a lot of fluid in here, this could actually compress the blood vessels bringing blood to and from the testes, as well as the lymph vessels, right? So that would become a problem. Okay. The next condition I don't have a picture of, but this will be called a spermatocele. This is a cyst that's going to occur with fluid as well as sperm, right? So this would have to happen after puberty. And that cyst is going to develop between the testicle and the epididymis. If you remember the epididymis, I'm going to borrow this picture here for a moment. So here we see the testicle, and this comma-shaped thing here right on top of the testicle is known as the epididymis, right? This is where sperm is going to mature. So we can get a cyst between the testicle and the epididymis that's filled with fluid and even contains sperm. Now, this may be itself related to some type of developmental abnormality of the tubules, right? But again, it would have to happen after puberty, right? The boys can't make sperm until after puberty. And this would also have to be surgically removed. Okay. The next condition is known as a varicocele, right? So varicose kind of sounds like varicose veins, and that's kind of what this is in a vein in the spermatic cord. Interestingly enough, I put here it's more common on the left side. So let's take a look at that. So here they cut into the spermatic cord. We see that normally we would have the vas deferens here, the testicular artery, which isn't shown, and then the veins that bring the blood out this way, right? This would be the testicular vein. Normally, you may have learned it as the piniform plexus. It's just kind of this network of veins that leave the testicle instead of just being one vein. So notice these veins here are much thicker than they should be. Right? So they become like varicose veins, and we call this a varicocele. Right? The reason this happens is these veins develop without valves, and that allows backflow of blood into those veins, and the veins now swell and they become dilated. Now, that dilation, if I go back to this picture here, can actually compress the testicular artery bringing blood down, and that would be a problem again to the testicle because it's not getting its normal blood supply. Right, so that would decrease the blood flow to the testes, as well as not having enough blood going to the testes would affect the ability to produce sperm. Right, this would also have to be corrected surgically. Right, so this is known as a varicocele. The next condition is testicular torsion. So think of torsion as like a twisting. Here, the structures of the spermatic cord become twisted. So it's kind of like just taking this testicle and twisting it and turning it, and this all becomes tighter and tighter. This can become a dangerous situation because it could actually really excuse me, the testicular artery, and now this will die, right? Well, you'll actually have infarction, right? So that becomes like a true medical emergency. So here the testes rotate on the spermatic cord, compressing our arteries and veins. This could be spontaneous, but it can also be following some type of traumatic event. Like I said before, if that swelling and the torsion causes ischemia, the testes may become infarcted, right? You could have death to the testicle if that is not reduced, right? So they got to untwist that as quickly as they can. Right? Testicular torsion. Okay, let's take a look at two conditions that are related to inflammation and infection. The first one being prostatitis, right? So very simply, this is going to be an infection or an inflammation of the prostate gland. If it's an infection, we typically think of it as an ascending infection, meaning that there'll be bacteria, say, on the outside of the male penis, and then it works its way up through the urethra into the prostate gland. So we can look at it as four different types of categories. The one that we're going to focus on mostly on this lesson here is going to be known as acute bacterial, right? In this case, the gland is going to be tender and swollen, right, from the infection. And even in the urine as well as the prostatic secretions, there'll be bacteria and pus and just different types of white blood cells that are fighting off the infection. The second one is known as non-bacterial. Here, the patient will also have an elevated white blood cell count in the urine and the prostatic secretions, and the prostate is slightly enlarged, right? So there's something going on, but it's non-bacterial. The third one is a chronic prostatitis. This is as a result of repeated infections, right? And usually the beast or the culprit is Escherichia coli, right? That's the E. coli. So here the patient will have a slightly enlarged prostate. It'll be irregular in shape. One of the differences here is that it's going to be firm. Usually the prostate, if you were to palpate it, is kind of soft and boggy. Here it becomes firm from the repeated infections. Scar tissue develops, and we get obviously that fibrosis, right, is scar tissue. So that's going to cause the prostate to feel firm. And then finally, the last category is going to be asymptomatic but inflammatory. Okay, like I said, we're going to focus more on the bacterial infections. So let's take a look at the etiology of acute bacterial prostatitis. Like I said before, this is a type of ascending infection. Again, the most common beast or cause is going to be Escherichia coli. But I listed down some other ones that are possible: Pseudomonas, Proteus, Enterobacter, Klebsiella, Serratia, and Streptococcus faecalis. So who's at risk for developing prostatitis? Usually younger men with urinary tract infections. Older men, if they have prostatic hypertrophy, we'll talk about that in a future lesson. It's also associated with STDs, right? Sexually transmitted diseases. Or if a male is going through some type of procedure, such as catheterization, right, where they actually put a scope in through the urethra, and it can also be caused from a bacterial infection of the blood. I put here bacteremia. So now the bacterial infection would spread to the prostate gland. Let's take a look at some of the clinical manifestations, right? Whether it's acute or chronic. The patient will have dysuria, right? Painful or difficulty urinating. They'll have urinary frequency, meaning that they have to go multiple times, and they have to go like, I have to go now, right? It's just like a feeling of having to go right away. That is known as urgency. The acute form would include fever and chills. The patient will also have low back pain and lower abdominal pain, right above like the pubic bone. Decreased urinary stream as there's more and more swelling, right? As the prostate becomes more and more swollen, that's going to actually like compress the urethra. So the patient will have hesitancy, meaning that they got to go. And they'll be trying to go, but they have trouble getting it going, get the process going, right? So hesitancy is where we have just a problem in initiating urination. Once they do go, right, they may not empty the bladder completely. Some systemic signs that could also be present would be fever, malaise, anorexia, achiness, right, like muscle achiness. If somebody does have a non-bacterial prostatitis, they'll have all those urinary symptoms that we just talked about, signs and symptoms. However, the systemic signs are less marked, right? These things we typically see more with infections. So again, if it's a bacterial infection, right, they're going to do antibacterial drugs. You know, culture the beast, find out what it is, and then give a specific antibiotic for that. And then if it's non-bacterial, they'll give anti-inflammatory medications. Okay, the last condition that we want to take a look at is known as balanitis. This is a fungal infection of the glands. Remember, we said the glands is the tip of the penis. This is typically, usually, sexually transmitted, and the causative agent is usually Candida albicans. Um, Vesicles will develop in patches right on the tip of the penis. They'll be burning and itching, and they'll just give a topical antifungal medication. Okay, so that concludes this lesson again on some of congenital disorders of the penis, some testicular and scrotal problems, and then some infections. In our next lesson, we'll take a look at some tumors of the male reproductive system.